Physicians set for Medicare pay hike under draft regulation. Welcome to Expert Billing Talk. Today, we're zeroing in on the Centers for Medicare and Medicaid Services proposed rule and what it means for how doctors get paid. Okay, let's unpack this. So the big news seems to be this proposed 2.5% increase in the base Medicare rate for doctors starting in 2026.
That's right.
Which feels significant, especially when you think about the cuts physicians have faced recently. Wasn't it almost 3% down this year?
Exactly, a 2.9% reduction this year. So yes, this proposed hike is a change of pace, but it's not entirely out of the blue.
Oh, how so?
Well, this particular 2.5% boost, it was actually mandated. Congress and former President Trump included it in a tax bill.
Ah, okay. So legislation driving this specific bump.
Precisely. And interestingly, that same legislation provides even higher increases for doctors who are in those alternative payment models, the APMs.
Right, nudging doctors towards those models. So how does CMS even figure out these payment rates? It sounds complicated.
What's fascinating here is it is a structured process, though it has a lot of components. They use a formula based on three main things.
Okay.
First, you've got relative value units, RVUs. Think of those as measuring the work, the resources needed for any given procedure.
Got it, like complexity points.
Sort of, yeah. Then there are geographic price indices, GPCIs. That adjusts the payment based on local costs. Makes sense, right? Delivering care in Manhattan costs more than in, say, rural Nebraska.
Sure, that tracks. And the third part?
That's the conversion factor. It's the magic number that turns all those RDUs and geographic adjustments into an actual dollar amount.
Okay.
And the key thing here is that this conversion factor gets adjusted every year. CMS aims for budget neutrality, so overall Medicare spending on physician services ideally stays level, even if individual procedure payments change.
So these specific proposed increases for next year, how do they break down with that conversion factor?
Right, so for physicians in APMs, the proposed increase to the conversion factor is higher, 3.83%.
Okay.
For other doctors, it's 3.62%.
And that difference comes from that same legislation you mentioned.
Exactly. It was part of that bill, sometimes called the One Big Beautiful Bill, which gave a 0.75% bump specifically for APMs versus 0.25% for traditional Medicare fee-for-service.
I see.
Plus, separate from the conversion factor, the draft rule also proposes a small 0.55% increase to the RVUs themselves.
So a few different levers being pulled there?
Yes.
Yeah.
And the punchy truth, really, is that after years of watching Medicare payments shrink or barely keep up with inflation, this proposed increase is a bit of breathing room, even if it's just temporary for now. It signals some recognition of the financial squeeze on practices.
Here's where it gets really interesting. CMS isn't just tweaking current payments. They're proposing a whole new mandatory payment model.
Ah, yes, the ambulatory specialty model.
Right. Starting in 2027, 5 years long, mandatory participation for some specialists. And it's a two-sided risk model. What does that actually mean for the doctors involved?
It means they have skin in the game, basically. They'll be responsible for improving care for specific conditions initially, heart failure and lower back pain.
Okay.
If they succeed in providing better care more efficiently, they could earn bonuses. But, and this is the two-sided part, if costs go up without quality improving or quality drops, they could actually owe money back to Medicare. They face potential losses.
So real financial consequences tied to outcomes. How will CMS measure that?
They plan to use the MIPS value pathways. That's the Merit-Based Incentive Payment Systems Quality Program. It looks at various things, quality metrics, cost efficiency, patient experience, even how well their technology systems work together. It's a definite push towards value. And if we connect this to the bigger picture, CMS is also looking at telehealth.
Ah, telehealth flexibilities. What's proposed there?
They're proposed to make it simpler to add more services to the list of Medicare-covered telehealth options, basically streamlining the approval process.
Makes sense given how much telehealth use exploded.
Exactly. And they'd also allow doctors to provide direct supervision for certain services, like cardiac rehab, using video calls, audio, visual tech, instead of having to be physically in the same room.
That could definitely increase access for some patients. Now, what about the existing programs, like the Medicare Shared Savings Program for ACOs? Any changes there?
Yes, CMS is looking at risk there too.
How so?
They're proposing to limit how long some ACOs can stay in the one-sided risk track. That's where they can share savings if they reduce costs, but they don't face penalties if costs go up.
Okay, so they want to push them towards
Towards two-sided risk, where they are accountable for potential losses too. The goal is clearly to get more ACOs fully invested in managing costs and quality.
But I heard there might be some relief for ACOs as well, something about patient numbers.
That's right. A big hurdle for some ACOs has been meeting the minimum number of Medicare beneficiaries, 5,000 patients.
Hmm.
Starting in 2027 under the proposal, new ACOs in the Shared Savings Program would get more time, 3 years, to reach that 5,000 minimum. That could really help more groups, maybe smaller or rural ones, get involved.
Interesting. It seems like CMS is also asking for feedback beyond these specific rules.
They are. They put out a couple of requests for information. One asks for ideas on rules or regulations that could potentially be repealed, part of their deregulation effort. Basically, what red tape is getting in the way.
Okay.
And the other asks for public comment on new ways to address chronic illness and improve prevention efforts within Medicare. So they're looking for fresh ideas from the outside.
So what does this all mean? When you pull back and look at all these proposed changes, the pay hike, the mandatory model, the ACO adjustments, telehealth, it's a lot for practices and patients to think about.
It really is. Short-term financial boosts mixed with longer-term pushes towards significant accountability and different ways of delivering care.
Understanding these shifts is absolutely crucial for anyone in healthcare today. And, for practices trying to navigate these complex rules and ensure their billing is accurate and collections are strong, help is available. Human medical billing works with U.S. practices specifically to fix billing issues, boost collections, and really help them take control of their revenue cycle. You can learn more over at humanmedicalbilling.com. We also have a great free weekly resource, the Expert Billing newsletter, packed with insights. And right now we're offering a 100% free practice analysis, no strings attached, no commitment needed, just a chance to see where things stand. Check it out at humanmedicalbilling.com.
That leads to a good final thought for everyone listening. What aspects of these proposed regulations do you think will have the most significant impact on how healthcare is delivered in the coming years?
Thanks for listening to Expert Billing Talk. See you next time.